be on the side of the operating table, and the arms will be docked through the oral cavity in dots. Usually the mouth is kept open with a retractor, and this is a vision card where you have all the settings for the power source, and this is the monitor for the assistant and the nurse to see. So what is the advantage of robot? It gives a magnified, super magnified 3D image with the depth perception, true time depth perception. So it helps in operating in cavities where your hands cannot reach, and the instruments are endo-wristed. So it can replicate the moment of your wrist inside a cavity with the smaller instruments. The only problem with this robot, current robots, is tactile feedback. You don't know what you are holding, what is the feedback. When you know, in oncology, in cancer, usually we palpate the tumor and cut around it. But here you don't have the touch feedback sensation. And other problem is the large footprints and cost. This is how a setup looks like. So this is the patient. Here, mouth is kept open with the retractor and 3 arms are docked. This is where I'm sitting in the console and controlling the robotic arms. These are the arms through which we can control, move these arms. This is the vision card. So a mouth is kept open with many retractors. You can see this is a classic FK retractor where you can keep the mouth open with all retractors, so you can dock the robot. Why this is some modification we have done because we know, because you're all you're well versed with submucous fibrosis. It is a unique problem to our patients where mouth opening is less. We cannot put such a big retractor and keep the mouth open. So we put a simple Estes mouth opener and put the robotic arms. So again, you can use various joints, retractors, all that. These are different retractors which can be used. Docking is usually done with the inverted pyramid fashion where camera is down and 2 working arms are there. So these are the various instruments which can be used. These are the instruments like these are fenestrated bipolar, monopolar hook, monopolar scissors. So different instruments are used. And coming to the powered instruments, we don't have saw in the robot. So usually if you have to have bone, if you have to cut the bone, you need to use saw after undocking the robot. So why a transvaal robotic surgery? As I told you, usually to approach a small tumor in either the back of the oral tongue or in the posterior 1/3 of the tongue, we need to cut the mandible, split the lip, split through the floor of the mouth just to approach this. And most of these surgeries are currently done either in a salvage setting where patient is already failed chemoradiation and organ preservation protocol. So when you do such a big surgery, healing is a big problem. We are going to give a lot of morbidity with swallowing and speech because of splitting of the lip and the jaw and the cutting of the muscles and nerves. So to overcome all this, you can avoid this access procedures and use robot through the oral cavity to do these surgeries. So currently for me the indication in oral and oropharyngeal cancers is mainly post chemoradiation failures, because we have excellent response with chemoradiation for tumors of the base tongue and tonsils. So most of the times we don't offer them upfront surgeries unless there are some special indications. But there is data for use in early T1, T2 oropharyngeal cancer as well. Then mostly other palatal tumors like spinal salivary gland tumors like mucoepidermoid carcinomas, where the upfront surgery is the main thing. We use the robot, and non-squamous oropharyngeal tumors like minor salivary gland tumors and some base tongue tumors and benign tumors benign tumors also, and also it is being used in obstructive sleep apnea surgeries, and also to be precise, using it in cleft palate repair as well. In some centers, they have started using for cleft palate repair because you can see the dissection of the mucosa from the muscle is so good. The collateral damage is so less. The injury to the surrounding structures is good, and the fistula closure rates are higher. So as I told you, advantages is motion scaling. Small motions can be scaled up. Tremor elimination, dexterity in a very limited space can be used. So just quickly go through a few cases. This is a patient who had a T4 tumor of the tongue. You see the whole this MRI showing complete involvement of the near total complete involvement of the tongue. Patient had upfront chemo radiation, which she responded beautifully, and at the end of the treatment she had a small residual disease, mostly in the tonsillolingual sulcus. Somehow this area seems to be resistant sometimes to radiation. So we did a transoral robotic resection, and now you can see this is post-op scan. Patient is doing well. It's now almost 3 years since the completion of the treatment. She is doing well. This is a quick video of. So usually once the camera goes in and it will expose the target organ, and now I'm showing, you can see with the monopolar scissors in one hand, the right instrument, and the left side I'm having bipolar. So we keep cutting you can, most important thing is to assess the tumor beforehand, before docking the robot when the patient is under anesthesia. You palpate because there is no tactile feedback once the robot is docked. You make your mind where your mucosal cuts are going to come. You can see the vision is so good. The camera is, as I told you, 3D with magnified 3D image along with depth perception. Bedside assistant helps in suctioning and retraction. As we proceed, you can see how you can nicely dissect and cut the precise delivery of the power at the tip of the instrument. So you can dissect up to the pharyngeal muscles, and also expose the medial pterygoid there. And the final part of the, once we have done all the mucosal cut and soft tissue cut, we undock the robot and use a saw to cut the mandible and deliver the specimen. See if I can forward the video. This is a fast forward video, so because I have a couple of more cases to show, so I thought I'll just see. You can see how nicely we can see the thing. Usually it takes longer time. This is all the video has been run fast. So the tumor, I'm getting the tumor off the pterygoid there, and with traction, counter traction, we leave at this point, undock the robot, and then you use a saw and cut the mandible and remove the tumor and do the reconstruction with whatever soft tissue flap we can. So this is another patient who had again a base tongue tumor. Here, sorry, palatal tumor. You can see I'm using a monopolar scissors in one hand, and can see how nicely you can visualize and take a good margin on these tumors. You can do it without a robot, but if you have it, it is good to use. You can see how comfortably we can dissect from the palatal muscles. If you see, this is where actually I did some literature search. They've been using it for cleft palate repair at few centers. These are the minor salivary gland lesions. You can see the endorist movement. It is almost mimicking our this thing. The vision is so good. You can see the vessels so nicely. So the collateral damage is less. And also you can feel the disease from the muscle here, taking adequate margin from the normal tissue. Definitely there is a lot of advantage when you use it. You can see the vision is really so good. The magnification what you get, even with magnifying loops, you don't get this vision. You can see each layer and the fascia over the muscle, and you can see that is not reached by the tumor, so it is peeling off so comfortably. So the chance of fistula is reduced quite significantly. The most important thing again is there's another case similar, based on tumor. Again, it is same. I don't want to waste time. It is similar. You can see exposing the lesion. And most important thing is to exposure. If you can see the tumor, you can operate without much problem. Again, a similar case of tonsillar cancer where we done that. That is a monopolar scissors, just to show the instrument. So once you see the lesion, you can take adequate margin on that. So this is a unique technique we developed where we are patients with limited mouth opening. We are putting a port. Usually we put the ports through the mouth, but we have started putting the port through the nasolabial groove. Put a small stab incision and put the port so that there is no clash between the arms. We are on the verge of publishing this. So this is again another case similar tonsillar malignancy where we have done robotic resection with the bedside assistant is very important because it has to keep suctioning the fumes and the blood and shows the margins to cut. Usually this is called lateral oropharyngectomy or radical tonsillectomy, where you go up to the superior constrictor muscle, go through the superior constrictor muscle and expose the parapharyngeal fat pad. Beyond that will be the carotid. We should be careful. Once you see the fat, you see that beyond that will be the carotid artery in the neck. So exactly carefully you dissect, because again, as I told you, we don't. You have to read the scans well before you do the surgery, because sometimes there can be a retro parapharyngeal carotid where you may injure it accidentally. At the same time, you have to take adequate margins. So this is some data regarding the DOS and radiation. So all this I will skip. So the future of robotics is going to be, especially in head and neck, is going to be single port robot where all the three arms will be in the same port. So it will occupy lesser space through the whole cavity. Currently in India we don't have single port robot, but it is going to come in near future. AI planning regarding the margins, then fluorescent guided margins for tumor surgeries. So careful selection of tumor and patient is very important. Surgeons should be well versed with open procedures before considering patient for transoral robotic surgery, because if you are not able to expose the tumor, you have to know how to do open procedure. All these cases should be discussed in a tumor board, where what is the best for the patient, because just because I know how to do a robotic surgery, I should not be doing, where a patient can receive non-surgical treatment. And management of neck in these tumors, whether you have to dissect the neck or not, whether the patient has received free of party, because all that will change again a lot of post-operative sequelae like healing. If you open the neck, the communication between the whole cavity and the neck, then you need a bigger reconstruction, can result in salivary leak and carotid blowout. So when there is no need, we should try to avoid the neck. When there is no need, that's why I told management of neck and levels to be dissected, whether you do all the levels or what are the levels to be dissected. And most importantly is intraoperative specimen examination and margin, because when you are doing surgery through this, they are in different dimensions. Tonsil is in one plane, base tongue is in one plane. So you have to orient the specimen with the pathologist. If you have a pathologist coming to the theatre, it is the best, but it cannot happen all the time. But if not, you have to draw a diagram and pin the specimen to the diagram board and tell them which margins you want, because margin status plays a very important role. Then reconstruction, either you do local flap, free flap, depending upon the need. Then tracheostomy and feeding tubes. Okay, this is our team. As one person cannot do what best needs, patient needs. So this is what I try to convey. Transoral robotic surgery is an option for oral cancers, especially base tongue tumors and tumors coming to the posterior part of the anterior tongue, and palatal tumors, and some non-squamous cell carcinomas, tumors of the tongue and base tongue. The robot can be used for a good, better outcome. Thank you.